Hello, happy Teach Me Tuesday. I'm Lisa Houston, your local nurse educator, here to give you a quick rendition of today's topic. As promised, we are doing NRP Part 2, which I do think is going to be a 4-part series, so it's going to be perfect for the month of December. Today, we are going to dive into the next part of the algorithm and kind of what to expect as codes escalate and the care of the baby needs to advance further past ventilation. So as you might recall, last week we talked about the history of NRP, how it was created to have a standardized approach to the resuscitation of newborns. We talked about how PPV and thermoregulation were super important, and teamwork and all of the people, that are involved in this. We're going to go through the algorithm a little bit further, kind of what to expect as we escalate care, and how having more than 7 people present really requires us to have great coordination for these babies. So our key takeaways from part 1 of NRP really focused on 3 things: thermoregulation, ventilation, and role identification. So starting with thermoregulation, we begin warmth at the moment of birth. We're warming, we're drying, we're getting the baby on mom. If this is just a regular term newborn delivery, that's still our goal, is to get the baby skin to skin on mom, to get warm blankets on, to do some stimming and drying as we're doing that. If it's a baby who we're going to do some delayed cord clamping on, that then may need to go over to the table, so baby less than 34 weeks or having some problems, even if we're doing delayed cord clamping, remember, we can do that on mom, we can do that on the perineum, where we are stimming the baby, getting them in some dry towels. If they're a micro premature baby, handling them softly, getting them in those small warm towels, and then getting them over to the warmer and covering them with plastic. Ventilation, as you might recall, there's a lot of repetition in NRP, and here we are with some of it. Ventilation is the single most important step of resuscitation, and that if we can get a baby ventilated well, the baby is going to do much better. The number one reason that babies have issues, whether that's at a delivery or in the NICU setting, is ventilation. It's not cardiac, it's pulmonary, it's respiratory, it's ventilation. The number one sign that your ventilation is effective is rising heart rate. So taking those steps of Mr. SOPA to correct that if our heart rate is not coming up. And then role identification, having the right number of people in the right role with effective communication and task completion, that comes back to that closed loop communication. Here is your 2.5 ET tube. Thank you for the 2.5 ET tube. I am going to call respiratory. I've called respiratory. Everyone in the room knows I have completed the task so that whoever delegated it knows, hey, that's not on my plate anymore. So those were our key takeaways from that first part of the algorithm. So now we're going to get to the place where we've done Mr. SOPA, right? You'll recall that from our last slide deck as we went through those steps of Mr. SOPA for effective ventilation, and our heart rate is remaining less than 100. So the A of Mr. SOPA is alternate airway. So that means it's time for intubation. So we have some indications for intubation. When our heart rate is persistently less than 100. That means we have tried the mask, we've tried pressure, we've tried suctioning, we've done some ventilation, and Mr. SOPA hasn't worked. Or our heart rate is less than 60 and we need to do compressions. NRP guides us that best practice is for the baby to be intubated prior to chest compressions being initiated. That's a great perfect scenario if you work in a care center where you have a nurse practitioner or a doctor available at any time that can come and intubate your baby. If you're not in that setting, or your providers are unavailable because there's multiple situations happening at the same time, or they're at a delivery where it might be at night and you have less people, you might end up doing compressions first, but the majority of the time we are going to get the baby intubated, get the A of Mr. SOPA, the alternate airway, inserted prior to starting compressions. So we know we need it. So what do we need to help us be successful? We need to have a handle and a blade. So we have different size blades for babies. It goes from 000 up to 1, 2. I'm sure there's way bigger numbers for like adults, but I don't even like to imagine what that would be. In the NICU, we primarily use a double O, a O, and a 1. Those are the 3 most common things you will see, with really even kind of narrowing it down even further to the double O and the O being the primary ones. Those triple O's really are for babies less than 24 weeks, but often it's not even going to be a long enough play to be able to visualize the vocal cords. Now, I am not a licensed person that can intubate a baby, so I have only intubated fake babies while teaching NRP or any sort of mock code or simulation, so I can only tell you what I've seen on those babies, and it's already difficult enough for me, so I'm right in my nice lane where I want to be as a nurse educator. So you also then need a tube. So when you're thinking, what tube should I select? NRP has a age and a weight guidance, so pretty much 28 weeks and less, we're going to consider a 2.5. 28 to 34 is going to be a 3.0, and 34 on is going to be that 3.5. You're going to have to look at your baby. If you have a 28-weeker that has severe IUGR, a 30-weeker with severe IUGR, or a 30-weeker who's LGA, right? We might have to do something different in those environments. But again, these are guidelines to say, hey, in the majority of situations, this is what we have found to be successful. Having suction available, having a stethoscope. Some providers want the stylet. Then having your resuscitation device, which we already have because we've been doing PPV, whether that's a T-piece resuscitator or a flow inflating bag. So most likely you're going to have a T-piece resuscitator of some kind, whether that's a NeoPuff or a NeoT, whatever it is that your facility has. Making sure you have the right number of people. Want to make sure we have the provider, a nurse, a documenter, an RT, and then maybe someone else kind of circulating. So about 5 people present during this intubation. And then having something to secure your ET tube with, whether that's tape, brown tape, plastic tape, a neo bar, whatever it might be that you're going to secure your tube with. And when you think of the order of events, so we know what we need to do, we have what we need ready to go. So what are the next steps? We want to try to get our heart rate to the most stable place we can so that it's not dropping. If we're at that place where our heart rate is less than 60, we might be in a little bit of a rush because we cannot get that heart rate above 60. But if our heart rate's kind of in that 60 to 100 zone, have we gotten it as high as we can, doing some of that PPV before the provider attempts. Each attempt should take about 30 seconds, and then we should be using PPV in between with the bag mask attempts if the first attempt isn't successful. And then from there, using a CO2 detector like a PD cap to confirm placement, in addition to the other ways we would confirm placement, which would be obviously x-rays is going to be the gold standard. Can't do that right away always. So mist in the tube, rising heart rate, CO2 detector. Remember, if your cardiac output is really low because your baby's heart rate is really low, again, you may not get color change on your CO2 detector. So mist in the tube, equal breath sounds, no breaths over the abdomen, rising heart rate, and then any sort of color change if that does happen. So our baby is intubated, and now our heart rate is less than 60. So we need to move down along in our algorithm. It's time for us to start chest compressions. So our indications for chest compressions are heart rate less than 60 despite PPV through an ET tube with chest rise. So we see these other indicators. Or if our heart rate is less than 60 despite PPV in a setting where we don't have a provider present. I think a lot about NRP is divided into this essentials and advanced learners. And when you think about maybe your special care nursery, depending on how far away that is from your NICU or from your providers, they too might have to start compressions before you get there. If the code team takes 3 to 5 minutes to get somewhere because of literal logistical distance, those people might need to be starting compressions in order to get the baby to a good place. And again, if you're in a situation where your team is not available because they are busy with something else, you as a bedside nurse may need to start compressions. At a delivery, I'm thinking of those precipitous deliveries where maybe we don't have the team gathered yet, or a baby that we weren't expecting to come out and be stunned or to have issues. That we don't have a provider present who can intubate, then we're going to start those compressions. So NRP tells us that the best practices is to move to the head of the bed. The number one reason for that is so that the rest of the baby, everybody has access to, whether that means they're going to need to put in a line, needle the chest, do a blood draw, maybe get x-ray in there, whatever they're going to need to do. The person providing PPV and the person providing chest compressions are right there at the head of the bed, freeing up the rest of the baby. The coordination is happening between the person with doing the PPV and the compressor. The compressor should be counting out loud. 1 and 2 and 3 and breathe in. That's our pattern, much faster. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. Those ands are important. The ands are our pauses. 1 and allows for the chest to recoil and the heart to refill. 2 and 3 and breathe and allows for exhalation, a moment of exhalation in between the compressions. So we should be doing 90 compressions and 30 ventilations in 1 minute. 120 things, 120 events in 60 seconds. It's fast. 1 and 2 and 3 and breathe in. 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 1 and 2 and 3 and breathe in, right? You gotta sneak in your own little breath. So, and again, we're next to each other so that we don't have to be screaming kind of back and forth in order for the leader to be able to communicate what they need, the documenter to be able to hear what's going on, and then everybody else in the room to have situational awareness. We should be auscultating the heart rate every 1 minute, and that's the time to be considering changing your compressors. So we're going to talk about this briefly in the documentation section, but just as a preview, during chest compressions, the heart rate should not be taken from the monitor because the monitor can often pick up the compressions. So during compressions, we want the heart rate to be taken during that moment of auscultation. So whoever's auscultating could be counting it out. Less than 60. Okay, we're above 60, we can hold compressions, right? That quick thing so that everyone in the room can kind of hear what's going on. So as we're doing chest compressions, we want somebody to be at our code cart, beginning to drop our medications. NRP really has 2 main areas of recommendations for medications, and then there's some, other ones that are discussed during resuscitation, but primarily we are going to be using 2 meds, epinephrine and fluid replacement. When we think of epinephrine, our indications are for that heart rate less than 60 despite coordinating compressions and ventilation for 1 minute. So we've done at least a full cycle of ventilation and compressions, and the heart rate is still 60 seconds. We have 2 dosing routes. They used to have like ranges of dosing, and NRP kind of now just says like, hey, let's do this. This is our best practice. So your ET tube is often the first access point you have. That dose is going to be 1 ml per kilo. It should be given right down your ET tube and then bag immediately after with your resuscitation device. If it's being given IV, IO, UV, whatever that is, it's 0.2 mils per kilogram. When you're thinking about your epinephrine and you're thinking about the lungs, it's great. It's quick, easy access. The epinephrine has to get down into the alveoli, into the capillary bed, be absorbed by the capillary blood, circulated back to the heart. So it's not the quickest of absorption. So if you have an IV or UV or a PICC line, whatever it might be, that is always going to be preferred. It's not like, hey, you do this first and then you can do a UV. It's if you don't have IV access, then you would do an ET tube dose first. Epinephrine can be given every 3 to 5 minutes, with the only difference being if you are changing routes. If you've given an ET tube dose and then you're going to be giving a IV dose, you can give them closer together because of that poor absorption. Think about anything that could be in your lungs that's also going to be preventing absorption, whether there's fluids there, whether meconium, the baby has pneumonia, there's a collapsed lung. So anything that could be kind of inhibiting of the absorption of the epinephrine also would indicate, hey, maybe we need to give this via IV. Best practices tell us that we should follow all IV doses with a 3 ml flush of normal saline, just no matter what your baby's route is. ET tube is often first in deliveries or in a code where a baby's a little bit older and doesn't have access. And then doses can be given close together if their route is changed. Our other medication that we talk about is fluid replacement. Our indications pretty much fall into 3 categories. If you know that the baby has a known fluid or blood loss, so placental abruption, uterine rupture, a cord accident, something happening where the baby is bleeding out, and we know we're going to need to give more blood. Hypovolemia. This is one we might see more in a NICU setting where we know we have signs of poor perfusion, weak or absent capillary pulses, prolonged capillary time. Those situations we know like, hey, we probably are going to need to give some fluids to help this baby. Even if in a setting where we don't have a known Blood loss, if we have a prolonged resuscitation with an adequate central perfusion, so that heart rate remains low kind of despite everything we've done, that is also going to be an indication for fluid replacement. We're primarily going to choose between two fluids. That's going to be normal saline or packed red blood cells. The dose is going to be 10 mils per kilo. Often we're working off of estimated weights in the delivery room. So for the baby's 3 kilos, we're going to give 30 mils of either normal saline or packed red blood cells, and they're given quickly, over 5 to 10 minutes. And then if it is the red blood cells, you do want to follow it with your flush to kind of get it out of the line. So that's our two primary medications that we're using in NRP, epinephrine and then fluid replacement. So we pretty much are going to need access and a delivery. Our number one point of access is going to be our UVC. Our pros here is that it's a big vessel. It can handle a lot of fluid, a lot of blood, a lot of medication. It's pretty easy to put in if you think of the delivery where you have kind of the bigger umbilical vein. A provider can put that in a relatively quick fashion, usually within 3 minutes from starting. But you don't always have an umbilical cord. So if we're talking about a baby in the NICU, they probably don't have their umbilical cord anymore. So this really only works in those first few days of life. There is an infection risk. This doesn't always tend to be a perfectly sterile procedure. So there's a little bit of infection risk. Many units will give a dose of vancomycin after they place this line, and it'll actually be removed and a new one will be put in sterilely in the NICU. We can do IO, intraosseous. So if you have, those are known for easy insertion. They also can handle most meds. I remember the last time we got our IO training and the rep was like, oh, you can't give chemo through it. And I'm like, if we're giving chemo, I'm too scared to be doing anything anyway. So I'm good there. So we can still give blood through that, whatever we may need. Some cons is it's tricky on small babies. They don't have a ton of area. They do require extra training. They're not used as often, so people aren't as familiar with them, including the nursing staff not quite knowing what goes through. A peripheral IV is a quick insertion. Babies often already have them. Bedside nurses are very familiar with putting IVs in. They can have some medications put through there. However, their cons is that if baby has poor perfusion. So let's talk about that 2-month-old who is coding in the NICU setting. If they are 2 months old and coding, they probably have poor perfusion. That's going to affect your success rate. The catheter is small. We can't put a lot of meds through there. And if their peripheral circulation is poor, the IV may not last as long. But those are our 3 main types of IV access lines that we would be using in a code situation. Now, if we're at this stage where we have medications and compressions and all that going on, we definitely need to have someone documenting. The documenter often is one of the most pivotal roles because they are keeping the cadence and the timing of the code going. We want to keep one documenter throughout the entire code. That documenter should use one clock, be talking out loud, asking clarifying questions, be consistent in their own documentation, and remind others of next steps. So we need to be documenting when chest compressions begin. Could we be documenting earlier? We can. Some places might be using a code navigator in their Epic, but just to note, if you're just giving PPV, that doesn't always document or require documentation on a code sheet. But if we are doing compressions and moving past there, because compressions should be happening before epinephrine, then we need to be using some sort of code documentation. Being consistent to yourself is going to be the best thing you can do. If there's a line that says like chest compressions, you could put a Y, you could put a check mark, you could write yes, you could circle it, whatever you do, as long as you're consistent with yourself. The documenter is calling out those key times that are in the algorithm. It's been 1 minute, let's stop and check the heart rate. It's been 3 minutes, we can have another dose of epinephrine. We have given 1 bolus, that was over 5 minutes. Do you want another bolus? They're kind of keeping that cadence of, hey, what could we do next? What could we anticipate needing to do next? Do we need to switch compressors? How we called the parents? What are things have we tried? Have we considered transilluminating the chest for pneumothorax? So lots of things that can be going on with the documenter. It's a big role, and make sure you always sign your document if you are doing paper charting for that. So to recap, we've gotten out of just NRP part 1, where we talked about PPV and those first steps and how important ventilation is. And now we've progressed to this chest compression, medications, where all providers become essential and the teamwork must be fluid. The team leader, the documenter, and the bedside nurse are really going to be having this close collaboration, making sure we're asking for the med. We're getting the med's being documented, it's being given to the baby. If we have these quick interventions and we adhere to the algorithm that NRP has lined up for us, that is what is going to give our babies the best opportunity for success at recovery here. So thank you for joining me for part 2 today. Obviously, I love to talk about this. This is my longest video yet. I'm so sorry. Next week, we're going to dive into part 3, special circumstances, things we do in the NICU, how simulation helps us, all those fun things. So join us back next Tuesday for another round of Teach Me Tuesday. Have a great day.